So these were my take-home messages. I paraphrased them a little bit so they are less complicated than on the slide. But if you want to look it up later on, you will see it's two-folded. On one hand side, we have a crisis, a vast gap in skills, digital skills, and we need to fix it if we want to address the health workforce crisis. What is the health workforce crisis? You all have heard about it. Shortages in the first place, shortages in family doctors, shortages in nurses, shortages in long-term carers, but also in some very critical areas. We have shortages in cancer nurses. Cancer has evolved over the last 20 years into very complex therapeutical pathways, and we don't have enough. That means we have difficulties with access, and that is absolutely critical. You could go on like this. There are shortages at the moment, and the worrying thing is we have at the moment unprecedented levels of health workers in the system. The headcount is higher than ever before. We have increased them constantly, and we have general shortages in health systems and long-term care. Attrition. Many people that get training in health and health systems, they are leaving the service very, very early. And in particular, it's nurses, in particular, it's long-term carers, social care, which are leaving. And this is sunk cost. This is a catastrophe because we are losing these very experienced people. In my country, Germany, conservative estimates 600,000 full-time equivalents of trained, qualified health workers are not working in the health system. Just to give you a kind of ballpark figure for comparison, we have 440,000 medical doctors. So if we could reactivate these people, we will probably resolve much of the health workforce crisis. Skill mix and skill gaps, and it's not only digital skills, but I will talk about digital skills today. It's plenty of skills. Actually, our training systems are broken. They are not really functioning as they ought to do. And this crisis is not going away anytime soon because we have problems with replenishing the health workforce. We have more demand because the population is aging, more elderly people with multimorbidities. We have an avalanche of retirees in the health system coming, and we are not recruiting fast enough people because also the cohorts from which we can recruit are actually shrinking. So we have a problem, and we need to think about how can we do better with what we actually have. And of course, we're all starting from different positions. There are still some countries where I would say, yes, you probably can still produce more doctors, more nurses, but many others have big difficulties. You already saw this from Chris, this beautiful little graph. I think we know what to do. There's not so much question. We don't need to ask about the evidence. The strategies are clear. No matter how you cut the cake, it's about investment, supply, retain and recruit, optimize for performance, and the planning. These are key issues. And at the moment, I think it's fair to say that policymakers in most countries are actually focusing on retention and recruitment because they are firefighting. They are firefighting the problem, what they have at the moment. And I think rightly so. That's what you do at the moment. But we have a twin challenge. It's not only about firefighting and trying to avoid the worst, but it's also to plan for the future. And even if you don't like the word, I will use it now. We are heading for a big transformation of services. We are transforming our service delivery systems. We are going towards primary care, or we are strengthening primary care. Care integration is one of the issues we are all looking forward. Hospital sectors are meant to contract, and we will provide much more services closer to the patients. So this is all very well known, but just to talk about the health workforce, which we need for this, and I present you five innovations in skill mix in the health workforce, which have proven to work. These 5 innovations were identified in the world's largest overview of reviews on skill mix innovations. And the first one is, which really works, is nurses in dedicated health promotion and prevention roles. So it's nurses that do nothing else but health promotion and prevention. And the reason is that usually family doctors would do this, but then they say, I have so many urgent things to do. I have so much on my list. I don't have the time for health promotion and prevention. And actually, I'm not very well qualified for all of this. So the model is like, for example, in Slovenia, each primary care unit has half a full-time equivalent of a nurse dedicated just for health promotion and prevention. Second is advanced practice roles for nurses, pharmacists, and physiotherapists. Almost all countries have this in the meantime, but to different degrees in terms of the numbers, but also the autonomy of these professions. So, for example, advanced practice nurses in Finland have much more autonomy, much more opportunities to do than in other countries, but also pharmacists. And if you walk here through Brussels, you see in front of some of the pharmacies a yellow banner, and that means that in this pharmacy you can get vaccinated. This was almost a civil war before COVID-19 between the pharmacists and the medical doctors. The pharmacists always wanted to do this, and the experience of COVID-19 make that possible, and it's much more convenient for patients, actually. Skills for new settings, hospital at home, chemotherapy at home, all this is taking place. In most countries, we have at least pilots on this. Very clearly, you need slightly different health workforce for this. You need different skills. You need different people communicating with others. Patient navigators. I loved one of these, I think it was Juan, who showed the complexities of health systems, but also the social complexities and so on. And some people can't go through this maze alone. They need somebody take them by the hand and help them to navigate. Because in many countries, we have all the services, but how to connect them, this is so hard. And not only for patients, very often for informal carers as well. And then teamwork. We know the complexity of dealing with patients that suffer from multimorbidities. We need complex teams that can respond to it, and we need to have the communication. And probably you already guess what I'm at. We're getting a much more diverse health workforce. We are getting many more people working together, actually, working together. And this is only possible, this form of care integration, if we have the digital tools for it and if we have the competence to use them. And I think this is one of the key problems we see at the moment. And just let me start with one anecdote. Belgium has started the electronic patient record in 2019. It's based on a law from 2004, actually. And if I look up my electronic patient records, there's almost nothing in it, except a couple of PDFs on blood tests. And the reason is, I have a great family doctor, but he's still taking notes by hands and puts it in a folder and not really using systematically this file. And it's not a single experience and it's not a single experience in Belgium, and it's not a single experience in Europe. I was sitting on Monday on a panel next to the deputy director of the digital health service in Spain from Galicia, and she said, same with us. Our medical records are half empty. There's not much in it, actually. Not of use. And you have so many other people that need to have access to it. Not so much in my case, because I'm not super sick, so that's still okay. But who knows, in 15 years, in 20 years, it would be great if a lot of health professionals would have access, and it's not. But there's nothing in it. And taking notes by hand is nice, but it's the wrong skills. It doesn't really work. And I had seen policymakers in private meetings having tantrums because they were arguing, we have invested billions into the technology, everything is there, and we don't get the digital dividend because it doesn't work, because the people are not using it as they should, and there's a skill issue in here. And just to let you know, there are ways to deal with this. Actually, we know exactly what are the basic digital skills, the basic digital health literacy needed. And these are basically five different categories. It's digital literacy, communication and collaboration, safety and security, problem solving and analysis, and digital content creation. And this is much smaller than it actually looks, because if you look into existing training schemes, some of these are 5 hours training, 6 hours training, 8 hours training. It's perfectly suited for professional continuous development. And it's, I think, not only for health professionals, but it should also be for patients and informal carers as far as they accept this. But to be honest, the availability of digital skills education and training courses is currently not sufficient in the EU. And we know this because we are setting up a database on these courses in the framework of the Be Well project. And I should say here, Ludmila is here with us, who is the project lead, the program manager for the Be Well project. It's a really fine project. I think please all eyes on it because something great is coming out of it. And we know what the situation in Europe is. There are, of course, a couple of hidden training courses which come with companies that are selling devices. But overall, there are not enough training courses for continuous professional development, not even in English, and in other languages, it's even worse. And we've been doing focus group interviews with leaders in health systems, and what we consistently got was there's no time for training at the moment. We have a health workforce crisis, all hands on deck. We can't afford this. This is what they say. And this is why we are using the digital tools insufficiently, and we are not making a difference. So what can be done? Also, if you look through the literature and the experience of people, it's the usual suspects: leadership, strategies, systematic approaches, sufficient funding, legally embedding digital skills in education and training requirements, cross-sectoral cooperation is needed, and technical infrastructure needs to be there. No brainers. You could do this almost for any other reform project. But the question is, why is it not happening? I just got one more slide. Why is it not happening? Because training in most European countries is a regional competence and not a national. And we've heard from Juan, Barcelona as a fantastic beacon, of using technologies. And apparently also they have the skills, all the skills. And I was talking to Nika and she said, yeah, we know in Valencia it's similar and in Aragon. But as I said, many other regions in Spain, it's not the same. And if we are talking here about Belgium, I think that Cienzano is actually not using the electronic medical records because either they don't have access or it's not good enough. They are rather doing surveys. So the situation is not that good either here. So it's a national competence. It's not a national competence. It's regional competence. Usually in the training, medical schools and universities enjoy a lot of autonomy, makes it more difficult. And of course, medical and nursing councils have a say in training, also in continuous professional training. So what can you do? And I don't see, is Clemens Auer here? We had like 10 years ago for the primary care reforms in Austria, we had a policy dialogue in Slovenia together with Veneto Regional and the Slovenes presented how they go forward with primary health care. And Clemens asked, how did you do this? And the Slovenes said, we won over the academic leadership in the medical schools. They take ownership in primary care. They take responsibility for it. And of course, they're not always doing what we want them to do, but they are going into the right direction. That makes it all much, much easier. Second strategy to do it is play it like the EU, have a budget line and invite organizations to apply for. If you want to train your staff, here's a budget, that's absolutely possible to use this then locally. And the third strategy is be France, because unlike most other countries, France has the constitutional and legal powers to impose curricular contents. Unbelievable, we couldn't do this. And even better, use all of the three above. So thank you so much.